to go. Dr. Laura Tochen will be presenting overview, classification, and basic approach to pediatric movement disorders. So I will go ahead and hand it over.
All right. Thank you so much for the introduction, and thanks again, everyone, for joining in. So I hope that everyone is able to learn something from the talk today. So we'll just do some basic overview and how we approach the classification of different movement disorders. And we might go into some basic treatments as well. So you can, and I have no disclosures. I will discuss some off-label use of some treatments, however. So hopefully by the end of this talk, we'll be able to describe the appearance of some different movement disorders, review some basic treatment strategies, and also review when it would be appropriate to refer a patient on to our movement disorders program here at Children's National. So the first breakdown in how we classify movement disorders overall is basically is there too much movement, is there an excess of movement, or is there not enough movement? So if there's an excess of movement, that's a hyperkinetic movement disorder, and if there's not enough movement, that's a hypokinetic movement disorder. And I've put some examples that would fall into each category. So hypokinetic movement disorders really fall into more of the Parkinsonism realm, so bradykinesia meaning slow movements, rigidity or stiffness in the muscles, and then hyperkinetic movement disorders, some examples there would be tremor, dystonia, chorea, tics, also myoclonus athetosis, spellism, and ataxia. I've put in bold the ones that we're going to try and focus on today because we don't, there are just too many to go into great detail in all of them. So I've tried to choose some of the most common ones, and you can click forward. So hypokinetic movement disorders are very uncommon in children overall, so we're not going to be focusing on those today, whereas hyperkinetic movement disorders are much more common in children, so we'll focus there. So in terms of just to briefly go over some of the pathophysiology of movement disorders overall, you might recall back from medical training, the indirect and direct pathway that was sort of the explanation for what's going on in Parkinson's disease and related disorders, where basically an imbalance of the dopaminergic input to the striatum leads to either too much or too little movement. And so this is just a complicated yet still at the same time vastly oversimplified diagram that reviews some of that circuitry. We're not going to go into great detail about it, but it's just a very quick reminder that this is the motor control pathways within the brain, so cortex to striatum to pallidus to thalamic, and then back up to the cortex. And there's both the indirect and direct pathways through the striatum as well. So we won't necessarily revisit that again. That's just a quick reminder as to what's going on. All right, so we can move on to the next slide. So really in movement disorders, what we do is we try and classify things based on their appearance, on their phenomenology. So I have a video here that I'd like to share with you guys to demonstrate. Hopefully it works. Oh. Uh-oh. Are the videos not working?
I am trying to play it, and it is not working right now. Let me see.
Does it? Do we have the plugins needed for the videos? Can I, let's see, Elizabeth, if I quickly email you the video files, would we be able to play them out of the PowerPoint? Could we do that?
That should work. Try that.
All right. So we're going to take a brief pause while we try and get those videos up and running. Let's see. All right. Okay, so some of the videos should hopefully be coming through to you. Did the email come through?
Sorry, I was on mute. No, not yet, but I am waiting patiently for them. Okay, I got your email with 3.
Okay, so some of them will have different labels, but for this first one, it should be labeled video 1. So hopefully this will work. Okay. So it's playing a little bit choppy, but hopefully, all right, so the timing in the video is being a little bit strange on my screen. I don't know how well it's working for everyone else, but I think that's good. So we can go back to the slides now. So hopefully what you should have been able to see was tremor, although the timing in the video was a little bit off, unfortunately, so I apologize for that. About a few years back, there was a task force on pediatric movement disorders that came up with specific definitions for all the different movement disorders that we can see and hyperkinetic movement disorders. So the task force really defined tremor as a rhythmic, back and forth or oscillating involuntary movement about a joint axis, or basically a fixed point. So what you hopefully should have been able to see in the video was some postural and as well as some action or kinetic tremor. So we classify tremors based on when you see them most predominantly. So you can have a resting tremor, which would be a more typical Parkinsonian type tremor, when someone is relaxed and not trying to use their limbs at all, versus a postural tremor. So you could hopefully see that in the video when the gentleman had his arms positioned in front of his chest. And then as well as an action or kinetic tremor, which is going to be more apparent when someone is writing. So this would be an example of a writing sample when someone's drawing a spiral. A is with a tremor, and B is a typical normal person with no tremor. And that was apparent hopefully in the video when he was going back and forth and touching his nose. So when we see someone with a tremor, we want to break it down and say, well, what could potentially be leading to this tremor, or what could be causing it? Tremor is really a symptom and not a final diagnosis. So the big things that we think about, particularly in kids with tremor, is could this just be an enhanced physiologic tremor, meaning everyone has some degree of tremor to some extent, and no one can hold their hands 100% completely steady, and some people might just have a more pronounced physiologic tremor than others, although certain metabolic things could contribute to that too. Versus is this essential tremor, which typically would run in families and usually doesn't pose much of a problem until later in life. Or medication-induced tremor can be very common too, and I have a list of some medications to consider when you're thinking about a medication-induced tremor. So is someone taking any of these medicines? Could they potentially even be super therapeutic on some of their medications? And then much less commonly, structural lesions or other neurological processes can be considered, but the top 3 are really much more common. Next slide. So in terms of studies to think about, I generally recommend that anyone who presents with a tremor should definitely have their thyroid function checked, because that would definitely be something that would be easily treatable and that you would not want to miss. Additional things that I often check, although less commonly would be abnormal, would be just general metabolic studies, make sure there are no metabolic derangements, vitamin levels, specifically like a vitamin B12 level, ceruloplasmin looking for very rare disorders like Wilson's disease with copper metabolism issues, but that's extremely rare. And of course, medication levels, if someone's on any of those medications that we discussed previously. And then generally an MRI tends to not be all that helpful unless they're really associated or accompanying other neurologic features, or if it's a unilateral tremor or something like that. And in terms of treatment for tremors, for the most part, assuming that it's not something that we need to treat like a thyroid issue or something like that, if it's really an enhanced physiologic or a familial tremor, most kids tend to not have too many problems, and we very rarely need to actually use medications. But in the rare instance that the tremor is causing significant issues, we can try medications like beta blockers or propranolol or sometimes primidone as well. All right. So let's see if any of these work. Okay, great. We have some videos now. All right. So I have a few examples of the same type of symptoms. So what you'll see in the video that's playing right now with this young man is that when he has his arms extended, that there's significant twisting and posturing in that right arm. And we can play this next video. And I'm asking this little guy to try and reach out and touch the toy that I have in my hand. And when he tries to do that, he also has issues with his accuracy, but you can see how his fingers extend and his arm postures, and you can see how the opposite arm is flexed at the elbow, and you can also see in the left foot that he has some inversion there as well. And in this child, when his arms are outstretched, that he gets this involuntary pulling so that both his wrist and his elbow flex, and he has difficulty maintaining a normal posture. And a little bit of difficulty maintaining posture when he points his hands away from each other as well. And then the last one is actually not a video. It's just a still picture, but a very extreme example of very severe abnormal twisting or posturing. All right. So these are all examples of dystonia, and by the task force, this is defined as involuntary, sustained, or intermittent muscle contractions, which cause twisting, repetitive movements, abnormal postures, or both. And so all of the prior examples were examples of dystonia, and I tried to show some that showed more twisting, and then some that showed more of the repetitive movements, like in that last video we looked at, where you can really have a more mobile or rapidly moving type of dystonia. So the way we classify different dystonias are, first of all, based on their location. So where in the body are you seeing these issues? So that can be either focal, segmental, multifocal, hemi, or generalized. So focal really means just affecting one muscle group. So for example, someone who only has dystonia involving their neck, like a torticollis, that's a focal dystonia just in one body area. Whereas segmental dystonia is two adjacent body areas. So if someone has dystonia that involves their neck but also their face, it's two adjacent body segments essentially, and so that's a segmental dystonia. And a multifocal would be two or more areas of the body but that are not adjacent. So if someone had dystonia in their left hand but also their right foot, that would be more of a multifocal dystonia. A hemidystonia is one that affects just one side of the body. So that was video that was on the top left of the screen was a hemidystonia, although I'm not sure I really showed you in the video what his legs were doing. And then a generalized dystonia really means it affects the entire body. So the child on the top right of the screen in that video had a more generalized dystonia. So we also classify dystonia based on type, or basically what is underlying it, or what the etiology of the dystonia is. So by old classification, we used to call things either primary dystonia or secondary dystonia. And primary dystonia were really the inherited dystonias where there were no other accompanying neurologic features, and the secondary dystonias were really any dystonia that was due to any additional underlying injury or anything like that. So secondary dystonias would include any cerebral palsy or anything like that. And people really wanted to move away from primary versus secondary, because really when that old classification was put into use, there wasn't necessarily a confirmed diagnosis for a lot of the primary dystonias. They were presumed to be genetic, but we didn't have identified genes for them necessarily. And now that we're becoming better and better at identifying genes, people have tried to update the classification. And so instead of primary versus secondary, where primary was genetic and secondary was either post-injury or something like that, we're now trying to move towards new terminology, which essentially mean the same thing, but the wording is a little bit different. So now we say, instead of primary dystonia, we're trying to call those isolated dystonias, and they are generally genetic. So for example, DYT1 or DYT6, where there's an identified a genetic mutation that leads to the dystonia, but the dystonia tends to be the only neurologic feature that accompanies their disorder, and they don't have any other neurologic problems. Whereas a combined dystonia, even though that can still be genetic, for example, some of the neurodegenerative conditions have dystonia plus other features that would put them into that category. And that could be either a traumatic injury, it could be cerebral palsy, or it could be some inherited neurodegenerative process. So in terms of treatments for dystonia, things have come along a bit, although we still are limited in terms of the medications that we have available. The mainstays of treatment tend to be anticholinergic treatments, trihexyphenidyl in particular, and for certain dystonias, depending on what the actual etiology is, we'll use dopaminergic agents like levodopa. There's some benefit, although a bit limited, to using things like baclofen or other muscle relaxants, and other things have been used more rarely, but probably with limited success. And what we are finding more and more with dystonia is that surgical interventions can actually be quite helpful, particularly for the primary inherited dystonias. So deep brain stimulation is being implemented, and there's a humanitarian device exemption in place through the FDA for many years now to use deep brain stimulation in children older, age 7 and above, into the globus pallidus for treatment of dystonia. And in the inherited dystonias, just from deep brain stimulation alone, we can see up to an 80% improvement in symptoms in the literature. So very promising treatment, and we're learning more and more about how surgical management for some of the previously called secondary dystonias or combined dystonias might still be helpful, although perhaps not quite to the same degree as the primary dystonia or isolated dystonia children. All right, so let's see if this one works. So in that video, what I want you to observe is that she has some sort of random, chaotic, somewhat fluid movements that are a bit unpredictable. So from each movement to the next, you don't necessarily know exactly what might happen as her next movement. And we can go on to the next slide. So this is an example of chorea, which is an ongoing random appearing sequence of one or more discrete involuntary movements or movement fragments that tend to happen in an unpredictable type of fashion. And so that was the definition that was come up with by that task force as well. And so in terms of how we would classify different forms of chorea, really acquired versus inherited is the major breakdown there. So of acquired chorea, there can be multiple different things that could lead to it, but vascular etiologies are something to consider. Immunologic acquired choreas are probably one of the biggest things to think about, especially in a pediatric population. So specifically, Sydenham chorea, which is a post-streptococcal phenomenon or rheumatic fever major criteria, and other paraneoplastic conditions as well. There can be chorea associated primarily with pregnancy, and there can also be metabolic causes to a chorea as well. And that's the acquired choreas are differentiated from the inherited choreas, which are actually, so of the inherited choreas, I would like to point out Huntington disease is the most common inherited chorea. However, juvenile Huntington disease only very, very rarely presents as chorea. The adult onset form is much more typically associated with chorea and the psychiatric findings. And in fact, juvenile Huntington patients have more of a hypokinetic type of syndrome, interestingly. But there are other genes that can be associated with chorea. Particularly, there are multiple genes associated with benign hereditary chorea, which is always something to think about. And in fact, some of them are also thyroid transcription factors, so chorea in any child who has any hypothyroidism, so those inherited conditions are something to think about. So I do want to focus on Sydenham chorea a little bit because that's still probably one of the most common causes of chorea in children, even though it's quite rare now in our age of pretty aggressive antibiotic use. So Sydenham chorea is post-streptococcal, and it's characterized primarily by chorea, but it's important to note that there can be a lot of other accompanying neuropsychiatric symptoms, so emotional lability, irritability, ADHD and OCD, psychosis, even, and so it's a much broader spectrum of symptoms rather than just the chorea itself, even if chorea is the predominant movement phenotype that we would see. And if you're suspecting someone to have Sydenham chorea, it's important to obviously rule out any other causes of chorea as well, but specifically you can look for any evidence of a prior streptococcal infection, so with an ASO titer or an anti-DNase B, but it is really important to keep in mind that those titers might not actually be all that helpful because the chorea can be, can occur 4 to 8 weeks after a strep infection, and so the titers can be variable, and certainly something like a swab or a culture might be quite useless because it's so delayed after the actual infection that the chorea itself would manifest. But of course, if there is a positive throat culture, they should be treated for a strep infection. And then a cardiac workup as well, because with rheumatic fever, of course, one of the major concerns is any cardiac complications that could occur. So treatment for Sydenham chorea, the most important thing is secondary penicillin prophylaxis, although I do want to point out that the penicillin prophylaxis is not actually a symptomatic treatment for the chorea. The antibiotics don't do anything for the movement disorder itself, but it's really to prevent any additional strep infections that would lead to any further cardiac complications. And the chorea itself tends to actually be fairly self-limited and resolves within weeks to months most commonly, but in very rare instances where the chorea is particularly problematic, we can do immunotherapy. So sometimes we'll do steroids with a steroid taper, or more rarely even IVIG or other immunotherapy treatments. Or for symptomatic treatment of the chorea itself, some people have used Depakote or carbamazepine as treatment options, although overall actual trials are fairly lacking at this point. All right, so let's see, hopefully this video works too. All right. So in each of these individuals, although of varying ages, they're all having these very brief, discrete, repetitive movements. And in this child here, you can actually see a much more coordinated sequence as opposed to just a single brief movement, that there's sort of a repetition or an order to the movements that he does. And this part of the video, although I'm not sure if it's actually working, there was sound with this last clip where each of those individuals, you could hear a sort of throat or guttural or a barking or a chirping noise that they were making with their movements. All right, so all of those individuals have tics, and so what is a tic? And basically, according to that same task force, it's a repeated, individually recognizable intermittent movement or fragment of a movement, almost always briefly suppressible. And so we categorize tics as simple versus complex. So simple were some of the ones we saw initially where it's just a brief movement, really just single muscle group essentially, versus a more complex tic like the child we saw slightly later on in the video where there's a more coordinated sequence of events that need to happen. And then we also categorize based on what the end result of the movement is, or the muscle contraction. So if the muscle contraction, the involuntary muscle contraction produces a movement, then that's a motor tic. And if it produces any sort of noise, then that's a vocal tic. So simple versus complex, motor versus vocal are just a couple of the ways that we'll categorize tics. So we can go on to the next slide. So additional characteristics that children or individuals with tics might display are that tics oftentimes have a waxing and waning course. We'll very commonly hear that one tic might appear and another one might disappear, and old ones might flare up again. They come and go. They have their peaks and their valleys. They wax and wane. We know that there are certain things that might bring tics out a bit more, and so certainly situations of anxiety or stress, which could be related to school, home, or anything else, can certainly bring tics out more, as well as fatigue. And so oftentimes we might commonly hear that towards bedtime is when tics might get a little bit worse as well. So a premonitory urge or some sort of sensory phenomena is a very common finding too, and up to 90% of adults with tics are able to describe something like this. Less so in younger children, and it's not clear if that is more because the younger children are less developmentally able to express what they're actually experiencing versus if they just don't actually experience this. But oftentimes people will describe some sort of either urge or sensation that comes before the tic that will intensify until a tic occurs, and then they will feel better after the tic occurs so that the tic has relieved this. And to explain it to kids, I oftentimes use like a sneeze analogy, and before you sneeze, there's a tickle in your nose, so you know the sneeze is coming, but you can oftentimes hold the sneeze in, so tics similarly are suppressible, but then that sensation, it just feels better once you let the sneeze out. Additionally, tics tend to be quite suggestible, so oftentimes the more you talk about the tics or the movements in the clinic, the kid might display more and more of them as you talk about them. So this is just a quick diagnostic tree that I've put together on how we put tics into their different categories. So anyone who's had tics for less than 12 months goes into a category of provisional tic disorder, and then historically this has been called transient tic disorder, and that's because a certain subset of those kids are going to grow out of their tics within the first 12 months, although you don't really know who's going to grow out of it or who isn't, and until they've actually grown out of it, it's difficult to really term it as a transient tic, and so that's why it was renamed provisional tic disorder, but it's still essentially the same thing. So if it's less than 12 months, they might grow out of it, they might not, but you don't really know, and so until you figure that out, they're provisional. Once you hit the 12-month mark, which is in fact a rather arbitrary time point, but that's what's been set by folks, so we stick with it. Once you hit the 12-month mark, then you fall into chronic tic disorder category. And then the divisions there are really based on what the symptoms are. So if they only have motor tics, then it's a chronic motor tic disorder. If they only have vocal tics, then it's chronic vocal tics. And if they have a combination thereof, then basically that's the criteria for Tourette syndrome. And on the next slide, I have the official DSM-5 criteria that was updated within the past few years for Tourette syndrome. So basically, you have to have both multiple motor and at least one vocal tic. They don't necessarily have to be present at the same time. And they wax and wane in frequency, which we already talked about is very common for tics overall. And that it's been more than a year since the first tic onset. In the past, with the DSM-4, the criteria had actually said that you could not have any tic-free intervals of more than 3 months at a time, but they actually removed that criteria. So even if someone has had a tic-free interval, but the onset was more than 12 months ago, they still would meet criteria for Tourette at this point. And as long as they're under than the age of 18 and there's nothing else that could contribute to that diagnosis, they meet criteria for Tourette syndrome. So they've over time made it much more easy for people to meet the criteria. And then I always want to point out to any family that comes in, because of how Tourette syndrome is portrayed in the media and in movies, people have a certain idea of what that really means. But in fact, there's nothing in the criteria for Tourette syndrome that says anything about severity, anything about prognosis. So overall, with Tourette syndrome, a third of kids are going to grow out of it with time, another third are going to have significant improvements, and the final third might still have some fluctuations into adulthood, but it's still very good odds for growing out of it. And there's nothing about severity in here, and there's absolutely nothing in the Tourette criteria that says anything about yelling swear words or coprolalia or anything like that, which is in fact an exceedingly rare symptom of Tourette syndrome. Anyone who does meet criteria for tics or Tourette syndrome, I do, however, always suggest doing quick screens for any other comorbidities, because there is a very high prevalence of psychiatric comorbidity lifetime in these individuals. And oftentimes these comorbidities can be even more problematic than the tics themselves. They can be even more disabling. And so more than half of children will also have ADHD. Approximately half of kids might meet criteria for OCD as well. And then other mood, anxiety, and depression are still in a third, and then disruptive behaviors, outbursts, and things like that are very common as well. And obviously you can see that all of these percentages add up to way more than 100, and so that's because more than half of people might actually meet criteria for 2 or even more of these psychiatric comorbidity diagnoses. So because they can be so much more disabling than the tics themselves, it is important to identify if there's any other comorbidity, and if there is, that deserves to be treated as its own separate issue, but does need to be addressed. And then this is a quick treatment algorithm that I follow. So the first step in your treatment algorithm is identifying if the tics themselves are causing any problems. Is there any, social implication? Is a child getting teased or bullied about the tics? Is it disrupting their academic functioning, making it difficult for them to complete their schoolwork or their homework, or disrupting the classroom in any way, or otherwise preventing them from doing the things that they would like to do? And if the tics are present, but they're not actually causing any of those problems, then one option is actually just to observe and provide education to the family and not initiate any treatments at all, because the tic itself is harmless. It's really only those secondary effects that we get concerned about, or those secondary downstream events. So if the tics are present and it's causing any of those secondary issues, that's when I would suggest initiating treatment. And our treatment options that we have at this point are divided into different tiers. And our first-line treatments, oftentimes it's very helpful to start with behavioral therapy, and there's a specific intervention for tics called CBIT, Comprehensive Behavioral Intervention for Tics, which is essentially developed out of habit reversal training and cognitive behavioral therapy that teaches people how to do some competing responses. So when they feel that urge or sensation to do the tic, that they can engage in this competing response type of treatment and substitute something else instead of the tic that would maybe be something that's more socially appropriate, but that could still lead to the same sense of relief. And that can actually be just as effective as some of our first-line medications. But if the CBIT is not available because there aren't that many people trained to do it, although we do have some people here at Children's who are now implementing this tool, or if they've tried it's not effective, then we can move on to our first-line medications, and that typically includes the alpha-2 agonists, so clonidine or guanfacine, and that's particularly helpful in individuals who also might have comorbid ADHD, as well as anticonvulsants as well. So topiramate is the one that's been best studied there. So second-line pharmacotherapy agents really are the neuroleptics, and we reserve these for children who have tried first line and have not been affected, who are really, or who have not improved, or for very severely affected individuals. And we do that because of just the higher risk for side effects with any of the neuroleptics. I've starred the ones that actually have FDA approval for tics. All the other ones are used off-label. Although haloperidol is FDA approved, I don't generally advocate for its use due to its side effects. I would more commonly move towards atypicals if I'm going to use neuroleptics, but all of these have been tried. And then for very, very refractory cases, third-line options include other medications. People have done local Botox injections. So if there's just one particular tic in one particular muscle group that's a problem, people have done Botox for that. And then on from there, people have, on an investigational basis, tried surgical therapies like deep brain stimulation, but somewhat limited success at this point. So that takes me through our quick overview of how to classify different movement disorders and how to evaluate them. So if you have any patients who have any movement disorders and you feel like you need some additional help in classifying or working them up, then that would be a good reason to send them on to our movement disorder program. If you, even if you've felt comfortable in making the diagnosis of a certain movement disorder, but there are any educational needs that need to be provided, and then you're not able to provide that in the office, then that's a great reason to send them on our way too. Or if you feel that any of their movements would require any treatments or medications, we're happy to help with any of that as well. So if you feel like you have any patients who would benefit from an evaluation with us, I have the appointment phone number here, as well as my email for contact. I also have additional resources that I oftentimes give to families as well. So Tourette.org is the Tourette Association of America's website. It has some great information and resources for families, as well as the CDC website has information about Tourette as well that can be very helpful to families. And then these are some of the teams that I work with. So our Tourette Tic and Movement Disorder Program includes me and Dr. Lavenstein. I have our pictures there, as well as in psychiatry. Dr. Dorfman helps in terms of managing a lot of those psychiatric comorbidities that we discussed. And then we have multiple providers here who have also been trained in implementing CBIT, the Comprehensive Behavioral Intervention for Tics. So Lauren Dome, who's one of our nurse practitioners, as well as 3 of our psychologists here have all been trained and certified in administering CBIT. I also work closely as part of our deep brain stimulation program, which we have up in place for children with dystonia. So Dr. Oligbo is our neurosurgeon, and Dr. Granata is our neuropsychologist, as well as our research assistants, Becky and Mary. And then our cerebral palsy multidisciplinary program with Dr. Rabin, Dr. Taby, and Dr. Keating there as well.
Great. Well, thank you so much. I don't know if we have time for any questions. We're a little bit over our time, but if anyone had any questions, you can go ahead and jump in.
I'm also happy to answer any questions by email if people think of things later.
Great. Well, thank you so much for joining, and thank you, Dr. Tochen, for this presentation. And we will have the presentation also on our website if you need to refer back to any of the slides. Thank you so much.
Thank you.
Bye.